Over to you, Dr. Abhilash.
Thank you, ma'am. Good morning, everybody. I'd like to thank Dr. Meena Nair for inviting me for this session. So, why do we check the optic nerve head in glaucoma? So, it undergoes characteristic changes in glaucoma that we need to recognize so as to be able to not just diagnose the glaucoma but also to quantify the progression and also classify it into early, moderate, or advanced disease. So there are various methods by which we can do this, and probably slit lamp by microscopy is the commonest one that we routinely use in the OP. Now, when we see the optic nerve head, we have to check a few characteristics of the optic nerve head. This is not just for glaucoma, but in any routine examination. One is the disc size and shape. Now, when the disc becomes bigger, the cup size and shape also differs with relation to the disc. The neuroretinal rim, which is the rim of neural tissue, which is found surrounding the central area called the cup. The retinal nerve fiber layer, which appears as striations both superiorly and inferiorly, and the watch out for any peripapillary atrophy. So coming to the disc and the cup consequently, it consists of around 1 million axons of the ganglion cells, but the size and the area of the cup varies a lot from around 1 to 6 millimeters. It's a big variation of the size of the disc. You can measure the disc size using the numbers on the slit lamp and then multiplying it by the correction factor depending upon which lens you are using to view the fundus. Usually it's vertically oval because the neuroretinal rim is thicker inferiorly and superiorly, the cup is usually rounded. Now, in a study involving Indian population, the average CD ratio was noted to be
Ask them
around
to put the
0.4,
timer
but
because I need to
around
know.
5% of individuals with 0.7 was seen to be having normal discs. Coming to the neuroretinal rim, now, as mentioned earlier, it consists of the axons, and because it's vascular, it appears pink in color. The Isn't rule denotes the thickness of the neural rim. The inferior is thicker than the superior. Then comes the nasal, and usually the temporal one is the thinnest. Always check for the vessel bending when you are looking for the inner margin of the neuroretinal rim. The circumlinear vessel is one that skirts the inner rim of the neuroretinal rim, and we'll come to it later why it is noting the circumlinear vessel is important. The retinal nerve fiber appears as I mentioned, whitish striation superiorly and inferiorly. So when you see a red-free photo of the disc, the superior part appears whitish because of the neural rim. The middle part, the macular region, appears to be a bit more darker, and then again lighter, brighter area inferiorly. It's best seen with the red-free filter and on photographs. Coming to the peripapillary region, there are a few things which you have to note. One is the scleral lip, which is the thin, even white ring that you may not see all around the disc, but you may probably more prominent temporally. And this indicates where the disc margin is. Gray crescent is a pigmented area seen most commonly temporally. It's a normal variation. It's more common in pigmented individuals. It appears as slate gray crescent, and this is a normal variation. Coming to atrophic zones around the disc, the alpha zone is a double layered fold of RPE, and because it's double layered, you have increased pigmentation on that side. And if the beta zone is present, this is usually present outside the beta zone. The beta zone itself is a retraction of the RP from the disc margin. So because RP is retracted, that area appears to be having incomplete or irregular pigmentation. It is also associated with absent or thinner choroid, and hence also more likely to be having glaucoma in that disc. So these are various photos of the peripapillary atrophic regions. Coming to the optic nerve head in glaucoma. So there are a few things which you have to note One is focal cupping. Now this is an indicator that the patient may be having glaucoma. So this is a selective loss of the neuronal rim, and usually it's seen vertically or obliquely. So this causes an enlargement of the cup either infratemporally or supratemporally, and usually these notches have sharper nasal margin and a more diffuse temporal side. Another pattern of cupping is concentric cupping, where there is the cup enlarges temporally and it's called temporal unfolding. Then it progresses circumferentially upwards and downwards. It's usually difficult to distinguish unless you have a drawing or a photograph of the patient in the previous visit. There could be a deepening of the cup also, and something called as overpass cupping, where you see the vessel that used to lie on the neuronal rim. Now the neuronal rim has gone, but the vessel is still seen to be bridging this deepened cup. Usually seen on slit lamp biomicroscopy. You can't make a 2D photo of that. Pallor cup discrepancy is important, because usually in glaucoma the cup usually regresses, the color usually stays there, so that's called a tinted hollow, where you have a cup but it's still pink in color. In advanced cupping, there is loss of all neural tissue and the disc appears very pale because of lack of vascularity. Sharp bending of the major vessels is seen at the scleral rim. This is called bean pot cupping. Laminar dot sign is not characteristic of glaucoma. This visible fenestrations of the lamina cribrosa. Another important thing that you have to check for in while seeing all discs actually, and one thing that you won't see unless you look for it, that is disc hemorrhage. It's more commonly associated with normal tension glaucoma, but in a case of diagnosed glaucoma, it indicates that glaucoma may be progressing. It is transient and it has a papillary as well as a peripapillary part. Usually the papillary part resorbs first. It's more common in the infratemporal quadrant, and it is an indication of active disease. It's usually seen in early or middle stage of glaucoma. It's a sign of progression and usually adjoins the notches or RNFL defects. So various photos of disc hemorrhages. Now bioniting appears as a broken vessel at the margin of the neural rim. This is because as the cupping progresses, the vessel bends more sharply and you don't see the bending behind the neural rim. So the vessel appears broken at the edge of the neural rim. Now the circumlinear vessel, as I said earlier, it lies along the inner margin of the neural rim, and when the neural rim recedes, this vessel seems to be moving more centrally. So this is called bearing of the circumlinear vessel. These are defects in the retinal nerve fiber layer, and they are more commonly seen with the red-free filter, where you find that the striations are lost. So the supratemporal and infratemporal area appears darker compared to the macular zone, which is reverse of the normal pattern. Now, among all these indicators of glaucomatous optic neuropathy, the stronger ones include neural rim notch, diffuse enlargement of the cup, RNFL defects, and disc hemorrhages. Most of them are better seen on disc photography. Coming to disc damage likelihood score, this was introduced by Spaeth et al. To grade discs into different stages. So you have it considers the size of the disc into small, medium, and large, and it compares the rim width rather than the cup size. And if you are really grading them, you have less variability, and this becomes very reliable. One moment. It correlates with function and is useful to monitor progression. The steps include: you have to dilate the disc pupil, determine the size of the disc, examine the disc carefully, and distinguish the outer rim of the disc. Note the inner edge of the NRR and estimate where the NRR is the smallest or thinnest. And if it has already met the disc edge, then you have to note the number of cloacas that the rim is absent. Always better to draw the ONH, determine the stage, and note it. Any stage more than 5 is unhealthy. More than 5 doesn't indicate glaucoma, but it is unhealthy. 1 to 3 are rarely associated with field changes, and up to stage 5 could be observed. Stages 8 to 10 indicate disability, and worsening stage requires aggressive treatment. Thank you.
Thank you, Dr. Abhilash. Any questions? I think I have a question for you. So, in the interest of the audience, if you were to choose between, though you have shown us the weak and the strong indicators, would you narrow down to just 2 or 3 pointers towards glaucomatous damage? What would you choose?
I think probably notching is probably important, and disc hemorrhage. Probably those two I feel be more important than the
Notching,
others.
yeah. So neuroretinal rim change and
Neuroretinal changes
the wedge nerve fiber
vascular
layer
changes.
defects, I think, are quite hallmarks. And disc hemorrhage, needless to say, very specific towards
In the setting of other changes, it is
glaucomatous damage. Yes. And I would like to emphasize that we are most of us are not practicing and utilizing the DDLS, and the youngsters should start giving more importance to it, because there's very little inter and intra observer, variation, more of an agreement if you stick to the protocol of the DDLS and stage it. It is good for monitoring as well as assessing the severity of the glaucomatous damage. Yes, Dr.
Meena?
Jayaprasad.
Yeah, good morning, Dr. Meena. Yeah, that was a nice talk, Dr. Abhilash.
Thank you.
And acquired optic disc pit. I heard a speaker recently, a glaucoma person, talking about acquired optic disc pit as an indication of glaucomatous damage of the optic nerve. Is it a well-established, accepted?
It is considered as glaucomatous disc damage.